of all, I would like to welcome all of you in this situation of COVID. Basically, Novartis has organized this webinar for the ophthalmologists, and all you know that glaucoma is not curable and vision lost and cannot be regained. So with the
फरहान साहब
medication,
एक छोटा सा इश्यू इधर पेशावर एंड पे आ रहा है कि हमारे कोई 15 कस्टमर इस वक्त कनेक्टेड है मगर लिंक उनका कुछ और आ रहा है।
अच्छा सोहेल आप जरा सा देखें।
मैं देख लेता हूँ।
सोहेल देख रहे हैं, मैं प्रेजेंटेशन
मैं देख
हाँ
लेता
सर
हूँ।
दोबारा कर ले बाकी हाँ क्योंकि वो
ठीक है
वेट कर
आप
रहे हैं
सोहेल देख रहे हैं, सोहेल देख रहे हैं इसको। अच्छा, diagnosis glaucoma is not always easy and careful evaluation of the optic nerve is very essential. So today we have very renowned teacher and professor of ophthalmology, Professor Mohammad Muin, with us, who will share his presentation case studies with us on the diagnosis and the management of the glaucoma and OCT interpretation. Before start the meeting, I would like to thank Dr. Professor Muin Yaqeen for his time, and now I'm handing over this podium to Dr. Muin. Sir, please start your presentation.
Assalamu alaikum, everybody. Welcome from Lahore. I'm sure it's a very difficult time for our country and for all the doctors. COVID ki situation mein it's pretty difficult. So it's an interesting topic. I think I thank Novartis and Farhan especially for arranging such a wonderful meeting. Or isme we are going to, what I'm going to show is optic disc analysis using OCT. Okay. So the disclaimer is here that the images have been taken from my book, and this is the book which we published, the Clinical Atlas of Optic Coherence Tomography by Paramount Publishers. So when we are going for OCT in glaucoma diagnosis, there are three things which we want to see. Is one is quantitative analysis of peripapillary retinal nerve fiber layer thickness, optic nerve head parameters, and ganglion cell thickness. Retinal nerve fiber thickness has better prognostic value than optic nerve head parameters, but some studies have shown that GCC is more accurate as well in showing pre-perimetric glaucoma is an entity, meaning that you diagnose glaucoma before the visual field defects show in. The new glaucoma structural diagnostic index includes retinal nerve fibers, macular GCC, and optic nerve head. So, what is the importance of OCT? Why we have stopped using visual fields, or why don't we rely that much on visual field? Is because 40 to 50% axonal loss may occur before any change in visual fields are detected. So what does the OCT usually show? It's a 6 into 6 millimeter, three-dimensional disc scan consisting of 128 B scans, with each B scan consisting of 512 A scans. Before I show you the whole of the report of the OCT, I'll just show you the different, or discuss the different printouts which you get. Number one is a shadogram. Here you can see the shadogram on the left as well over here, that it is a surface image of all aligned B scan, and it is usually used to check if the scan is reliable. The scan will appear sharp, indicating highest quality, and show no signs of fixation error on blinks. I'll show you in the next slide what I mean by that. And fixation error, blinks, and poor scan quality will all result in reduced diagnostic accuracy. So it's important to just quickly look at the shadogram before you start looking. The poor quality, as you know, is caused by media opacities, incorrect focus, or even dry eyes. Here you can see this is a shadogram showing high quality scan. That this quality is checked by the retinal blood vessels, if you can focus on them nicely. But if there is a fixation error,
sorry to interrupt, ये जो आपकी स्लाइड चेंज नहीं हो रही।
अच्छा,
नहीं स्लाइड तो चेंज हो रही है स्लाइड से चेंज।
अब हो रही है?
अब चेंज हुई है।
अच्छा हो गई, चले सर, I don't know, किसी वजह से हो रहा है। The shadogram shows high quality scan, but a fixation error. आपने देखा there's a break in the blood vessel over here in the area of the fixation error. And here the other slide shows a good no fixation error, there is no break in blood vessel, but the quality of the picture is poor. So you need to look at that. Then you come on to the temperature scan. When I started looking at these, I didn't usually give much importance to these scans. So, but it is important as well. It gives a quick representation of the RNFL thickness across the scan, with thicker areas appearing as warmer colors and thinner areas appearing in cooler colors. RFNL thickness is calculated, and observation of the temperature thickness plot can show whether the patient has a normal RNFL pattern and a highlight area of thinning. I'll show you in the next picture. A high quality scan is usually seen. Now, if you quickly look at this scan, what you see is that this red area above and below the optic disc, normally we are tuned that if something is red, we will say that this is thin, and it is as something is abnormal. But in the temperature scan, we have to understand.
चेंज नहीं हो रही
नहीं हो रही फिर
सर
करता हूँ
हो रही है, स्लाइड चेंज हो रही है, सम टाइम कुछ किसी का कनेक्शन डिले आ रहा होता है, इस वजह से उसका थोड़ी देर में हो जाएगी। लेकिन आपकी जो टेम्परेचर थिकनेस प्लॉट्स की स्लाइड है वही है यहाँ पे अभी रन हो रही है।
चले मैं उसको आगे रन करता जाता हूँ उसके हिसाब से आगे दूसरे पे भी लगा। सो चेंज हो गई है probably the healthy RNFL thickness plot. If you see, it is red over here in this area, and this is a normal plot on the left side, while the plot in the center, that is a cooler plot showing diffuse RNFL loss. So it is actually something which you're not used to, that if something looks all green, that means that the retinal nerve fiber layer had actually thinned out. It's not abnormal, it's abnormal in this instance. So that is important thing to look in the shadowgram. And this last one, you can see there is a mixture of both. The infratemporal area is green, while the supratemporal area is red. That means that the inferior area, there is retinal nerve fiber layer thickness, while in the superior there is not. So we'll just go on to the next, and I'll just probably there might be a lag with somebody, but the next one is the normative comparison, which you see. This is usually the patient's RNFL thickness is either classified as normal, borderline, which is 1 to 5% of the normal distribution, or outside normal limits within the bottom 1% of the normal distribution. So those are the three things. So the yellow is the borderline, which you see in this graph, and the outside normal limits is the red one. Then the normative comparison often shown is three different ways. One is the TSNIT chart. In the TSNIT chart, you can see this double hump, which you typically see is made by unfolding the retinal nerve fiber layer around the disc and making it straight. And that actually causes the retinal nerve fiber to become straight. And here, because the retinal nerve fiber layer is thickest superiorly and inferiorly. So this is the reason why you get peaking of the retinal nerve fiber layer thickness in this area. And the other is the 3.5 millimeter ring, which you see, which is made around the disc, and the retinal nerve fiber thickness is actually calculated between the disc margin and this rim. And then significant grid is sometimes it is some machines have a significant grid on the color photograph, and some have the significance grid on the shadowgram. Here, actually, it is different from the temperature scan. Here, if you see red areas, that means there is thinning in this area in these patients in this. So if we go forward to show this thing again, the measurement of optic discs can be useful in determining glaucoma risk. Large discs, if you see them, they can be more physiological cups. An average disc area has been calculated to be 2.8 plus minus 0.5 micrometer. And asymmetry in the two discs is important, as we all know, in patients with glaucoma. So the next question comes in. When you are seeing this green and red, these pictures on the on the normative or the normative comparison, what do they represent? These are from normative databases of people which the machine has been configured to use. So they're not very exhaustive and typically contain less than 500 patients actually. And they do not always include a range of ethnicities and refractive errors, both of which affect the retinal nerve fiber layer thickness. So non-glaucomatous myopic eyes tend to have a thinner retinal nerve fiber and will therefore be falsely classified as normal limits. So there you can see that is one slight flaw of the normative database. But if you know about that, you can adjust to your settings if you have any problem with this. This is again showing that the TSNIT chart. This is the typical double hump which you see, and this is normal, borderline, and the red area is the affected area. And the 3.5 millimeter ring is usually split into 2 and sometimes 3. One have got a 4-quadrant plot, and then you've got a 12 clock hour plot, which is present in patients in some of these patients. Come on to disc topography, and this is pretty simple, and you use the CD ratios, the disc diameters, which probably you're used to seeing. And the important thing to remember is always try to look out for the vertical disc ratio which you have measured and which the machine is measuring. That gives you some learning as well, that how well you are doing in calculating your retinal nerve fiber thicknesses. So then you've got your cup disc volume, rim area, horizontal. So I'll show you this as we go along as well. There are other slides as well. So important thing is, and then the other is trend analysis. In there's some machines which will show you different the serial RNFL thickness photographs or the scans of your patient, and that will give you a trend that is he getting worse or is he stable. So healthy subjects has demonstrated an age-related reduction in retinal nerve fiber thickness of 0.52 micrometer per year. So we need to know, that is why the normative database is different for older people and for younger people, right? So commercially available OCTs are typically able to measure retinal nerve fiber thickness with a reproducibility error of less than 10 micrometer, provided that the scan quality is high. So this is a comparative or a progression analysis showing you that the different changes in optic disc in the trend analysis which you're seeing. Here you can see initially we started off with baseline. This is follow-up 1. Follow-up 2, you see these red areas in this significance chart on the color that tells you there is thinning. So whenever you have the red and the green and thing, you always tend to look at the sidebar and see what it actually represents. Here you can see red is actually representing less than 1%. So this is the progression chart on the TSNIT. Then you come on to, this is your typical both eyes display of your retinal nerve fiber. This is an OCT report of a Triton Topcon machine. And here you can see this is the shadogram, which is called the superpixel. Then you've got the thickness map. Here the red area is normal thickness, because here you see the calibration below. Here it says 0 to 200 microns. So this area below is near about 150 microns. That's why it's red. Then this is the color photograph showing you the cup to disc ratio. And this is the TSNIT chart. Now you've got the quadrant display, then you've got the clock hour display, and then you've got the disc, and then you got the average thickness, and then you got the superior and inferior. As you know, there's a horizontal raphy, so you need to compare between the superior inferior difference. It is significant, then it shows you. This is the area I think will just show you, just to remember what this is. This is the opening of the Brooks membrane. Usually the machine is, how do they calculate the disc margin? The machines usually calculate the disc margin by looking at the end of the Brooks membrane or the RPE, which ends at the optic disc. And this is which it is showing that is the opening. We'll discuss it further as we go forward. Here you can see this is a scan which is showing retinal macular thickness, because we don't nowadays, we already pointed out there are three things. One is the retinal nerve fiber, the second is the retinal optic disc cup parameters, and the third is the ganglion cell analysis which we do. So it is important to see the ganglion cell. So this is the retinal, this is a composite map on the top cone in which you can see the retinal fundus photograph and the disc both together. Here you can see this is called the ETDRS chart, which we typically see in patients with macular pathology. So normally we would see this. So in this, they overlay the ETDRS chart. Then you've got the ganglion cell plus. That signifies the inner plexiform layer, ganglion cell layer, and the retinal nerve fiber layer. And then the GCL plus is the ganglion cell layer and the plexiform, inner plexiform layer. Actually, the ganglion cell and the plexiform layer has got the dendrites of the ganglion cell. So actually, it is the dendrites which are affected initially in glaucoma damage. So the theory is the retinal nerve fiber thinning is occurring at the disc, but actually it is starting from the dendrites, because there the mitochondria is present, and there is where you're getting the thinning of that area. And then you've got the cell body which affected. So that is why they say that the ganglion cells thickness sometimes precedes precedes patients with normal retinal nerve fiber thickness. So we'll go with that as we go on. Then this is the retinal fiber map where you see this. And this is another thing which we have got. This is the most advanced things which you can do when you are doing multimodal specialties or multimodal imaging. In this, you've got the OCT scan showing the TSNIT. This is overlaid with the retinal nerve fiber thickness is over here. This is overlaid on the visual field as well of the patient. This is called the Hood report, which is being used for advanced glaucoma diagnosis, which correlates all the different pathology which you see in glaucoma, including the retinal nerve fiber thickness, the ganglion cell analysis, and the visual field as well, all interpolated on each other. And this is a macular trend analysis. We saw the trend analysis of the retinal nerve fiber layer. The other trend analysis is the trend analysis of the. It is important to see this is the baseline. Normally, when you would see a macular scan, you would see this yellow area. Here, the yellow area is actually telling you, and you need to always see what this yellow area is representing. Here, it is not the significance chart. It is the thickness map. So the red or the yellow area shows that this is the perifoveal macula is healthy. You should see a yellow donut over here in normal patients. And here you can see on follow-up, this donut is fading away. If that fades away, that tells you that the perifoveal area as the ganglion cells are being affected. So whenever you're looking, now we have an idea of what the scan is, we just go on to some important 10 points in reading an OCT. Number one is make sure it is a reliable scan. You can check for the reliability by checking the numbers in his eyes. It's about more than 7 and is more than 7 or 80% in a figure in the top cone. But it will usually, even if you don't remember the figure, that area shows as red. So it is recommended to do 3 retinal scans at a time. The reason is because macular scans are much more predictive. The patient does not have to fixate eccentrically to get you into right place, but for the glaucoma scan, sometimes the patient has got fixation problems. So that is why if you repeat the scan and get the best out of them, that is the best one. You need both RNFL and macular scan. Why do you need that? Sometimes you might have just macular or retinal pathology patients with retinitis pigmentosa. If you just see a disc scan, you'll see, yes, the disc is pale and it has got retinal nerve fiber thickness, but you did not see the retina. The thickness, the thinning of the retina was happening because of the retinal thickening due to retinitis pigmentosa, and that was actually causing the retinal nerve fiber thickness rather than glaucoma. So that is why you need to have both of them. Can the retinal nerve fiber optic of your patient be applied to the normative database? Suppose if somebody has got an inferior coloboma, so it is not going to be applicable because there's going to be a defect in that area. Sometimes the machines don't have a normative database of very young children. That is why then at that area it might not be applicable. Then the next is, do OCT findings fit with the clinical presentations? What disease you're trying to see, is it fitting with that or not? And watch out for red disease and green disease, which I'll show you in the next slides. And there's a large range of normal before the RNFL reaches a tipping point. Normally, they say the visual field defects you start to see when the retinal nerve fiber layer falls below 77 micrometer. And usually the thickness is usually 100 or slightly higher in patients depending on the age of the patient. Then the OCT can show glaucomatous change before it is seen on visual field, which we discussed in the start. And change of 10 microns from the previous measurement is significant because of the different slides, different pictures which are taken by the machine. There can be some disparity between them. So you give that margin of 10 micrometer. And the last one is the SD-OCT is not as sensitive with more severe disease in glaucoma. That is called the floor effect, which is very important to remember. We think that if the patient has got a cup disc ratio of 9:1, I think the OCT is the best. OCT is actually not the best. It gives you that floor effect. In advanced stages of glaucoma, SD-OCT is less clinically useful due to a floor effect. With advanced, the retinal RNFL thickness levels off, rarely falling below 50 micron and almost never below 40 microns due to the assumed presence of residual glial or non-neural tissue, including blood vessel. At this level of disease, serial visual fields are more useful to judge the progression. So that is important. So here we look at a patient. Here is a scan. This is a scan which you see retinal nerve fiber layer thickness is all in red. This is the 4-quadrant display. This is the clock hour display. All are in red. Let's go and see what is the vertical cup to disc ratio of this patient. This patient is a cup to disc ratio of 0.8 in this. So probably the patient has got significant thinning, but he's reached an area where the retinal nerve fiber, average retinal nerve fiber layer is 50 or 40 millimeters a micron. So at this stage, you will not appreciate any significant area. Here you can see the shadogram on which the significance of the retinal nerve fiber layer has been shadowed. So here, this is shown in red, while if you look at the temperature chart, which is the retinal nerve fiber thickness, everything is in blue. Nothing is in red. That tells you that the retinal nerve fibers have significantly thinned out. And then you go on to see the macular area. Here we saw the area which is showing on this is the deviation map. So we have to check for the OD thickness map. So if you look at the top one and the one below that, sometimes we get confused. Why is this red and why is this blue? As I showed you initially, you should have a yellow donut around this area, around the macula, because the retinal nerve fiber layer is thick. It should be around 100, and that is not showing. So it's blue, so that means that the perifoveal area is thin in this patient. But this is the deviation map from an age-matched control. So this is from a normative database, and this is split the thing from the normal patient, and this is showing that this is decreased from that patient. We go forward, then we come on to an interesting concept in OCT of the optic nerve head, which I initially had some struggle to do to find out what it was, but the axon enters the nerve perpendicularly or sometimes obliquely. Oblique orientation shows a larger rim apparently when you see from above. If we look at this picture, we see this is the choroid showing the blood vessel, this is the sclera, and this is the retinal pigment epithelium with its Brooks membrane. So BMO is called the Brooks membrane opening. So in this patient in which the fibers vertically bow backward, here you can see that the distance is thinner. So if you measure the distance between the Brooks membrane and the internal limiting membrane, over here is thinner. compared to a BMO, which is over here, which you measure might be longer. This is the BT is the border tissue between the sclera and the RPE. So that sometimes can be oblique. That can give you an apparent appearance of a larger rim or larger rim when you see it clinically. As we go forward, you'll appreciate it more. So there's an entity which is called BMO MRW. So Brooks membrane opening, minimum rim width. The other entity is the horizontal rim width. Normally, we'll take the horizontal rim width first because that is an easier thing to understand. So the horizontal rim width will be where the Brooks membrane stops, and you make a horizontal line going on towards the over the axons and ending at the internal limiting membrane. This is the horizontal rim width, but that can change if the orientation of this disc is slanting or if it is perpendicular. So in order to get rid of that anomaly, they have come up with Brooks membrane opening and minimum rim width. That is, if you draw a line which is the shortest from the Brooks membrane opening to the retina to the internal limiting membrane, from that is the minimum rim width. So they say at the minimum rim width, all the axons will pass through. That is the reason that is very important. So if you measure that, that is your actual minimum rim width, which is important when you're measuring this. So let's see what happens when you are seeing an OCT scan, what you see clinical and what the actual machine is actually seeing. The machine sees if you look at this green spot, these green areas are the areas which show you the ending of which the doctor has highlighted, the green dots, but the red dots are the area where the Brooks membrane is actually ending. In order to easily understand, we've got the red area and then we've got the yellow line is the MRW or the minimum rim width. So here we can see we have a tendency to overestimate the rim area compared to what the machine can consistently delineate in this area. So smaller rim in reality compared to the rim predicted by the clinician. So therefore the patient has more glaucoma damage than predicted. So because it is going to calculate the cup to disc ratio according to this opening which the machine has measured from the Brooks membrane opening. Then we come on to an entity which is called red disease. Those are false positive. Red disease is when OCT mistakenly indicates that something is abnormal. Most commonly, the thinner retinal nerve fiber layer of a high myope doesn't conform to the limits identified by the normative database and is thus colored red. As a rough estimate, retinal nerve fibers are thinner by 1.2 micrometer diameter of myopia. So let's see on the OCT scan what they looks like. So this is a patient. This is an OCT scan. This is the shadowgram. This is the temperature chart, and this is the colored picture. What is the most striking thing you see in this patient in myope? There is peripapillary atrophy, and peripapillary atrophy, obvious at that area, the Brooks membrane opening and everything is going to be changed in these patients, leading to red disease, and the retinal nerve fiber looks 61 and 51, although the patient might be running in the normal limits. So in myopes, it's very important that you look at the ganglion cell analysis. That is what say the ganglion cell analysis is most useful for patients in myopia, where especially you've got peripapillary atrophy and where you can run into other errors of calculation. So if we go forward, the green disease in early glaucoma, there's a focal loss of RNFL. As you know, you can get slit defects or focal defects, which sometimes get thicker or deeper, or they can get broadened. So softwares are developed to take the mean of a given sector. So as we pointed out earlier, we have a sector scan and then we have a clock hour scan. So we need to look at both of them, because the sector scan sometimes shows, the clock hour sometimes shows an abnormal area sorry, the sector scan sometimes shows an abnormal area as normal by taking the mean with the surrounding normal area. The whole printout appears green, lending the appearance that this patient is normal. So this is typically a patient with green disease. So by looking at the quadrantic chart, you will see that everything is green to tell the patient you don't have glaucoma. But when you actually see the clock hour scan, you see that the retinal nerve fiber is thin here, is 53, so it's thinning, and that shows up over here. It's actually the averaging of this quadrant which has made this red area into green. So you always take the clock hour as significant areas in this. This is just to give you an idea what we are talking about, ganglion cell thickness and ganglion cell analysis. If we look at this, this is the retinal nerve fiber layer along with ganglion cell layer and the inner plexiform layer. And this area where you see this is normal and this looks thinner, especially on this side. So that tells you that this is a patient with glaucoma. So those are the key points which we've gone through. Next, we'll just look at some scans and make some discussion. It is well known the macula scans are more repeatable, accurate, and reliable than this scans. That's why fixation is steady over here, and this scans are more prone to subtle positioning error, fixation loss, and optokinetic nystagmus. Especially, you can also need to look out for disc drusen, tilted disc, peripapillary ERMs, and papal edema. All affect the accuracy and reproducibility of a disc scan. If you see the scan in the clock hour scan or the TSNIT going into white, you need to always be suspicious that the patient has got either disc drusen or he's got swelling of the optic disc. Now we go through some cases in which we highlight the importance of retinal nerve fiber layer thickness, and we correlate with that with ganglion cell thickness. Here you can see this is a patient who is 61 years old age. If we look at the color photograph, probably we see the patient has got a cup to disc ratio, looks like 0.6. If you see the temperature chart, you see that this is the red area superiorly, but it's more green inferiorly. So damage should be in the lower area. And the next, you should look at the shadowgram and you look at this area which overlaying a significance map, which is red area shows that the retinal nerve fiber is thinned in this area. And obviously in this area, so if you just go back and look, then you obviously try to see if there's an inferior notch in this patient. This is a colored photo, red tree photograph, and then you've got your TSNIT display. And here you can see this is the superior comes first and the inferior comes later. And here the inferior graph is actually dipping down, which you also shown in the inferior quadrant over here and also shown in the inferior clock hour display. And let's see what we thought was the cup to disc ratio. Looking straight ahead at the picture, we thought it was 0.6, but it is coming out to be 0.8 in this patient. And here the machine is actually trying to highlight the area of inferior notching, which we're trying to figure out. Because we need to remember the cupping is actually where the blood vessels are turning rather than the area of pallor which we see in this area. And here in the machine is showing you which it has taken as the opening of the optic or the optic canal, which is the Brooks membrane opening, and here it is highlighted the points which are the ending of the Brooks membrane, and this is the rim highlighted by the machine. An important thing, another thing which you see over here is a RD ratio, that is the rim to disc ratio. Normally we are more prone to seeing a cup to disc ratio, but it is actually the rim which has got the nerve fiber. So if you actually see and calculate the rim, probably they are significant as well. That is because that is actually what we're trying to see. Then we come on to the parameters. The cup to disc, the disc area is probably within normal range, is 2.05, is not very long or not very short. And then the other thing which we go on to is the ganglion cell analysis. It also important is it also gives you a foveal scan. So if there's any retinal pathology, you can obviously pick up this as somebody's got a retinal edema, you can also see in that. Now you go on to the main chart, which is the central one, which is the ganglion cell plus the inner plexiform layer. What we wanted to see was a normal yellow donut around the fovea, but the donut is missing inferiorly. So, and this is what you see in the average. Here you can see this is the significance chart. This is the superior inferior difference. So the superior is 67 and 54 inferiorly, and the average is given in the lower part. And this is when you've got the retinal nerve fiber layer calculated, added onto this area. So this is the area which you want to see in a ganglion cell analysis. So what we discussed was ganglion cell analysis is very critical to be used in myopic patients with peripapillary atrophy or retinal nerve fiber thinning, which you typically see in these patients. This is another patient. Let's look at the cup to disc ratio. Here the disc looks slightly, the rim looks thinner superiorly, and there is the cupping of the optic disc. So if we say that the cup to disc ratio is about 0.7, if we look at this, so looking at this vertical is 0.77, and this is similar if you look at the cup which has been identified. This is typical nasal shifting in this patient. Now you want to see on the temperature chart. Here you see this area is showing green area, so this is probably the area which is affected and which is also showing on the significant chart. But the important thing is the significance which you see is not very significant in this area superiorly. And similarly, this is another patient showing in this area. The reason I put this chart is I think we forgot to look at these lines. These are very important. These are telling you this is a patient which is showing you red disease because you are picking up artifacts which are actually causing this area to be shown in red, which is actually it is not. So then if you think the cup disc ratio is big, what you need to see is what is the disc area. So disc area is 3.7. So this is a big disc. So you always expect physiological cupping in a big disc. If it's 2.58, that is within a normal limit. And similarly, if you look on the left side on the shadowgram, you've got these artifacts showing up in this superior area, in this area. So this is in this picture. And you can also do anterior segment OCT to check for central corneal thickness, which you can correlate with glaucoma in these patients of. Now look at the scan. It is very important to look at the optic disc and then just to look at the overall picture of the retina of the posterior pole. You see that this retina does not look to be as healthy as it should be, looks more mottled or more tessellated appearance in this retina. Then let's see, the shadowgram shows the temperature chart. The shadowgram shows some area of thinning in the around the disc. Look at the clock arc chart. You see in the quadrant chart there's all green. In the clock arc chart there's area of borderline and red areas. We look at the disc area. Disc area is small, so this looks like a smaller disc. The cup to disc ratio is 0.6, so that is important. So try to physically see, yes, it looks like 0.6. Then we go on to the area of retinal nerve fiber thickness. Looking at the macular scan, here you can see we do not have our typical donut which you see. So we expect that this patient, we ideally need to have the ETDRS chart over here. And here the other thing which you are highlighting is the image quality of the scan is low as well. So that highlights some problem with the scan. So this is probably a scan which you have to accept with a thought that this might be somebody who's got macular pathology which is producing this area. So you correlate different things. You check for intraocular pressure. You check for if the patient is there. You check for any sequence change in retinal nerve fiber thickness or not. This is the central corneal thickness. Now we go on to another scan. Here you can see we got the superior and the inferior thinning of the retinal nerve fiber layer, which is seen on the quadrant scan. We correlate this onto the temperature chart. So the normal red areas, the red bow tie which you see is absent. And on the significance chart, you see the red area is present, superior and inferior to this. But you still see there's some error in acquisition. The patient has either blinked or looks like there's a blink, because usually when there's a blink, the machine cannot capture that area in that area and shows as a black line. The image quality is good, is in green. So the patient, the next thing what you want to see is the disc area. Is 2.2, is a nearly normal size. The vertical cup disc ratio is 7.9. Then you see the rim to disc ratio. This shows that the inferior disc looks more damaged than the superior disc. Then we go on to our retinal scan or the foveal scan. This looks pretty, the picture of the retinal scan looks normal. The foveal cut is good. And our normal donut, which you see, the yellow donut is present as well in the perifoveal region. And if we see over here that the ganglion cell analysis shows you that it is slight area which is being affected. The averages are slightly down, but still it is, the significance is still in the greener zone. So we would eye this or diagnose this with caution. Probably this would be typically a patient you would do a repeat scan. That is a patient typically you want to correlate why this is showing more and the retinal nerve fiber thickness is showing less over here. So this is another patient, is a borderline patient which we're trying to see. Again, let's try to see this. So this is another slight bit of image acquisition error in the shadowgram inferiorly, and this is shown in the inferior quadrant graph. The cup to disc, the disc area, which needs to be monitored and probably put on treatment in these instances. And any questions before we just give 2 points on Simbrenza? It's a wonderful drug launched by Alcon, which has got a combination of brinzolamide and brimonidine. So you do not get the side effects of beta blockers, and patients with asthma, I'm very comfortable prescribing them to asthma patients now, because with beta blockers, especially with the combination of timolol and dorzolamide, there were more problems in those patients. And typically we see that I'll just quickly go through some important things which I think are more important. The time waited between installation of first and second glaucoma medication. So the role of using combination is that you get more IOP lowering effect if you give a combination of two drugs, rather than a patient is usually hasty, they waste 1 minute and they just put in the drops, and you see the effect of the drug is not very efficient in those patients. And obviously the patient has got lesser drugs to instill in these patients. So it's acting on the alpha agonist area, which is reducing the aqueous outflow, and the alpha agonist, which is also outflow, is also being decreased by the alpha agonist, and the carbonic anhydrase in decreasing the inflow of this. So beta blockers are typically, which you see, typically the initial problems which you probably did not highlight before is decreased libido, depression, hair loss, skin disorders, which typically are seen, which are not seen in these patients. So fixed combination has potential benefits. There's additive, obviously the preservative exposure is less, the tolerability is less, and the patient adherence is less. Patient comes in, I've got so many drugs to put in, doctor, what have you given to me? So fixed combination should be considered when patients who fail their individual IOP with monotherapy, and is preferably to two separate installation, is more convenient and decreases the number of applications per day. So its preservative exposure is less, tolerability, dosing frequency, and adherence, which we all have seen. So therapeutic indications are the same, which we use. The pH is 6.5. So it decreases aqueous humus formation, suppresses formation, and increases uveal outflow, brimonidine as well. So then there was a combination with a fixed combination versus unfixed combination. And then there was a fixed combination versus individual components of the drug as well. So IOP lowering efficacy of Simbrinza was non-inferior to the unfixed combination of its individual components and compared to IOP lowering efficacy of Simbrinza to each of its individual components. So those are the main points which we wanted to highlight today in the webinar. So I think thank you very much for watching very patiently. It's very different experience for me as well, giving the talk because I don't see anybody. And I'm involved with a lot of people. Thanks to Novartis for arranging it. It's a great initiative, especially in these times. I hope you stay safe and you start your practice with caution and you take care of all the safety measures which we can. I'll be happy to engage in any questions, and during that time, I'll just flip over some slides which are remaining.
The forum is open for the question answer. Please.
Just one comment for Professor Moin. Professor Moin, though it's a different experience that you have not been able to see the audience, but you can see the attendance on your right side of the screen if you can. More than at this moment 80 people are have heard your talk, and that's actually excellent presentation from your side. Just a one comment from my side.
Thank you very much.
Audience, respected doctors, please, if you have any question related to this presentation, Dr. Moin is here, happy to answer your question and queries. Please unmute your mic or type in the chat box if you have any question.
Even if you don't have any questions, you can email to me or you can send it to Farhan, and I'll be happy to answer any questions. I thought initially when I was making the presentation that the glaucoma actually talk interpretation on OCT is pretty simple. You just look at this green circle and say you have glaucoma and you don't have glaucoma. But actually it is slightly more detailed, and the more you think about it, the more you start to understand things. And now I didn't touch upon the other thing is now they've gone over to actually using OCTA and checking the vascularity of the optic disc and predicting that for glaucoma analysis. So that is the future for glaucoma analysis to come.
So I would like to close this session, very interactive, very informative session from Professor Mohammad Moin Yaqeen. And in the last, on the behalf of Novartis Pakistan, I would like to especially thanks Professor Moin Yaqeen for his precious time and the expert opinion on the subject of glaucoma and the OCT interpretation. And also I will be thankful to all audience. Dr. Saab, if you have any concluding remarks, so we will be closing this meeting.
So my concluding remarks would be, now I think OCT is here to stay with us. Use OCT to diagnose retinal nerve fiber layer thickness in patients with glaucoma suspects or patients who have low tension glaucoma. But if the disease is advanced, you need to go over to visual field. But before you start patients on a lifelong therapy, just don't rely on IOP measurement and other measurements. You need to have a collateral document with the patients, because I was triggered by one of the patients. He comes to me that you started this treatment to me, and I went to somebody else and he said, you did not have glaucoma. Why did you start treatment? So if I had not done the test, I would have no ground to stand on. I had done the test and I showed you this is what it is. Yes, you did not have, your pressure was normal at that time, but you had thinning at that time and there was no other disease. So it is very important to document nowadays, and especially the patient is more satisfied when you tell him, when you interact with him, you show him the OCT, they understand and they look forward to understanding what glaucoma is. Because sometimes you say that, oh, I've seen this and you've got glaucoma, But the patient says, I don't know what the hell is he talking about. I'm seeing fine. There's nothing wrong with me. The other day I saw a patient who's 6'6", and I said, you've got glaucoma. उसकी पैरों के तले जमीन निकल जाती है. So thank you very much for watching. And
Sir,
we'll see you back sometime again.
one comment from my side that although it was a very nice presentation, and we are all aware that in the advanced stages the visual field examination is much better, but to diagnose the glaucoma in the early stages, the OCT is required. So I am very much thankful to Professor Mohammed to hear from you from Larkana and other Novartis people.
Thank you very much.
Thank you very much, sir.
So thank you very much. Thank you so much, all of you. Yes, is there any? Okay, thank you so much. We are closing this session. Thank you so much. Allah Hafiz. Allah Hafiz. Bye. Have a nice day.